Hello, dear colleagues. I'm very glad to meet you again this year. Today, together with our team, we're going to present you a subject of interest for our department, namely some aspects of modern treatment of uveitis. It includes a group of heterogeneous diseases characterized by inflammation of the uveal tract, with the incidence of 17 to 52 per 100,000 persons, and the prevalence variable from 38 to 714 per 100,000 persons. It's responsible for up to 20% of legal blindness in both the US and Europe, and up to 25% in developing countries, particularly among the working age population. Depending on the etiology of inflammation, there are infectious and non-infectious uveitis. About its incidence in children, it's more likely to be in boys than girls, and in adults, it's more likely to be in women than men. The greatest part, there are non-infectious uveitis, both in adults, 91%, and children, 95%. And the infectious form is about 9% in adults and 5% in children. Topographically, anterior uveitis occupies up to 4%, panuveitis 40%, posterior uveitis 43%, and intermediate 66%. Being an immune-mediated disease, non-infectious uveitis can be associated with systemic diseases like juvenile idiopathic arthritis, ankylosing spondylitis, Behçet disease, sarcoidosis, tubulointerstitial nephritis, inflammatory bowel disease, psoriasis, systemic scleroderma, and reactive arthritis. Patients with non-infectious uveitis are at increased risk of developing glaucoma, cataracts, retinal detachment, uveitic macular edema, and finally, blindness. Our purpose was to analyze the therapeutic features and to identify the advances in the therapy of non-infectious uveitis. We studied up to 450 articles from PubMed and Google Scholar, using keywords non-infectious uveitis, therapy, corticosteroids, biological agents, and we selected 50 relevant sources, which were considered representative. Here we present a list of them with some results and interesting facts. First one, there is a practice patterns regarding corticosteroid treatment in non-infectious uveitis, a survey study. 87 ophthalmologists were asked about this treatment, and two of the most commonly used remedies were dexamethasone implant, Ozurdex, and posterior subtenon triamcinolone, or Kenalog posterior subtenon. Regional corticosteroids were more commonly used as first-line treatment in more than 50% of cases of posterior uveitis compared with anterior uveitis. Respondents were more likely to use regional corticosteroids in more than half of cases of unilateral uveitis than in bilateral cases. The majority of respondents stated that they would avoid the use of regional corticosteroids in patients younger than 8 years. So these results demonstrate the more frequent use of regional corticosteroids in posterior uveitis, unilateral cases, and their avoidance in children. Overall, the variability of these responses highlights the need for regional corticosteroid use guidelines. Another study is about the efficacy of B-cell depletion therapy with rituximab in refractory chronic recurrent uveitis associated with Voiko-Yanagi-Harada disease. All patients received 3 infusions of rituximab. The follow-up period after initiation of the rituximab therapy ranged from 9 to 36 months. All patients achieved remission and visual acuity improved significantly. Rituximab provided control of inflammation. No rituximab-related complications were observed. In conclusion, rituximab is effective for the treatment of chronic recurrent refractory granulomatous uveitis associated with Voiko-Yanagi-Harada disease. Another study is about areas of agreement in the management of non-infectious chronic anterior uveitis in the UK. 26 of 38 uveitis specialists participated in the exercise, and responses rates were 100% for rounds 1, 3 and 92% for round 4. A consensus was reached on 23 of the 44 articles. Items for which no consensus was reached included management at presentation, use of systemic and periocular steroids in children with severe disease, and the role of conventional steroids sparing immunosuppressants beyond methotrexate. In conclusion, management uncertainty at the group level, as shown by the absence of consensus, reflects areas where too little is known. This study identifies case area for future research needed to ensure better outcomes for potentially blinding ocular inflammation in children. Here is long-term outcomes of treatment with biologic agents in eyes with refractory active non-infectious intermediate uveitis, posterior uveitis, and panuveitis. Results show that patients which were followed for a mean of 5 years, demonstrated active uveitis at baseline, and 34% demonstrated coexisting active systemic disease. Control of ocular inflammation was achieved in 87%. The mean oral prednisolone dose at baseline was 17 mg per day, and at 6 months it was reduced to 7 mg per day, remaining stable up to 5 years of follow-up. Best corrected visual acuity at baseline was 0.5, improved at 3 months, and remained stable during follow-up. After baseline, 42% of eyes had flares, and the mean number of flares decreased from 1.8 to 0.6 flares per year. Treatment failed in 33 eyes. The risk of treatment failure was lower when treatment used adalimumab, but was higher when systemic disease was also active at baseline. In conclusion, overall, eyes treated with biologic agents after failure of corticosteroids and a second-line immunosuppressive drug showed satisfactory disease control, reduced use of systemic immunosuppression, stable visual acuity, and the risk of relapse of the disease by 23%. After multivariate adjustment, old age, treatment with adalimumab versus infliximab, and concomitant inactive systemic disease were associated with a lower risk of treatment failure. Here is another study about JAK inhibitors in refractory juvenile idiopathic arthritis-associated uveitis. This is a case series study. 4 patients with a long history of juvenile idiopathic arthritis and associated severe uveitis were included. The indication for treatment with JAK inhibitors was uncontrolled arthritis and/or uveitis despite treatments with conventional and disease-modifying biologic antirheumatic drugs, or DMARDs. During treatment with JAK inhibitors, namely baricitinib, 3 cases, and tofacitinib, 1 case, all of our patients showed improvement in uveitis, defined as a reduction in intraocular inflammation according to standardized uveitis nomenclature criteria. However, we observed a different response to treatment between uveitis and joint disease, as the latter did not respond as favorably as the former. The treatment was well tolerated by all patients, and no ocular discomfort, ocular side effects, or allergic reactions were recorded. JAK inhibitors may provide available new treatment options for patients with GI-associated uveitis, especially in those refractory cases that do not respond adequately to conventional or biological DMARDs. Another study about the role of biosimilars in uveitis. A long-term world outcomes of the switch from original to biosimilars TNF-alpha inhibitors. So the aim of the study was to identify any change in the control of ocular inflammatory manifestation among patients with non-infectious uveitis switching from an originator to an appropriate anti-TNF biosimilar. 37 patients and 62 eyes with non-infectious uveitis undergoing switching from anti-TNF-alpha initiators to biosimilars were enrolled. In conclusion, switching to biosimilars represents a feasible treatment choice associated with maintenance of clinical efficacy in patients with non-infectious uveitis previously treated with appropriate originator anti-TNF biologic agents. Another study about biosimilars is about adalimumab and SB5, an adalimumab biosimilar in patients with rheumatoid arthritis. So this is a randomized study results. SB5 has been well tolerated for over 1 year in patients with rheumatoid arthritis, with efficacy, safety, and immunogenicity comparable to that of adalimumab. Switching from adalimumab to SB5 was uneventful during treatment. No increase in adverse events, increasing immunogenicity, or loss of efficacy were reported. Now study about periocular triamcinolone versus intravitreal triamcinolone and intravitreal dexamethasone implant for treatment of uveitic macular edema. The purpose of the study was to evaluate the comparative effectiveness of 3 types of regional corticosteroid injections for uveitic macular edema: periocular triamcinolone acetonide, intravitreal triamcinolone acetonide, and intravitreal dexamethasone implant. Patients were randomized 1:1:1 to receive one of 3 therapies. Patients with bilateral uveitic macular edema were given the same treatment for both eyes. In conclusion, intravitreal triamcinolone acetonide and intravitreal dexamethasone implant were superior to periocular triamcinolone acetonide for the treatment of uveitic macular edema. The risk of increased IOP was modest in all cases. Biological agents should be used with caution in the treatment of inflammatory eye conditions. Patients can benefit from either by reducing corticosteroids and avoiding their side effects, or by achieving better control of ocular inflammation. All patients receiving biological agents should be closely monitored. There is significant data showing promising results in the use of them. It's very important that doctors involved in the care of these patients, such as ophthalmologists and rheumatologists, know all the options available to better evaluate and treat these patients. Further studies of existing drugs and randomized controlled trials of additional targets will further refine this therapeutic option. Another study entitled Expert Opinion on the Use of Biological Therapy in Non-Infectious Uveitis. In the case of steroid dependence or sight-threatening disease, conventional immunosuppressive drugs such as methotrexate, azathioprine, and mycophenolate mofetil, and or biologic therapies such as anti-TNF alpha treatments, adalimumab, infliximab, can be used to achieve and maintain disease remission. Interferon is an effective immunomodulatory drug that can be proposed as second-line therapy in specific indications, for example, refractory macular edema, sight-threatening Behçet's uveitis. Other biological drugs, especially tocilizumab, are showing promising results. Local treatments, steroids, sirolimus, can be used as adjuvant therapies in case of unilateral recurrence. Therapeutic response should always be assessed by clinical examination and appropriate ancillary investigations. In conclusions, uveitis causes up to 25% of blindness in developing countries, and treatment remains a significant challenge given the heterogeneity of the uveitis spectrum and the potential risk of ocular complications. Corticosteroids are the conventional first-line therapy for non-infectious uveitis. Advances in understanding the pathogenesis of uveitis have yielded new molecular targets for modulating the ocular immune response and sparked a drive toward personalized medicine. Biological agents, biological DMARDs, have opened a new era in ophthalmology and are widely used, including in the treatment of uveitis. Janus kinase inhibitors and biosimilar biological agents are a promising therapeutic option for the treatment of non-infectious uveitis. Thank you all for your attention. Have a nice day.